the quest for elusive control, which is being given by the very knowledgeable Dr. Sebastian Crespi, who is president of Legionnaires International. We are delighted that Pall Medical have joined us again in supporting this series with an educational grant. Today we have a really good turnout, which indicates Dr. Crespi's international funding, with 600 registered participants from 46 different countries. Just before we begin, I have a few points of information for our participants. During the presentation, please do feel free to ask questions as you think of them. Sebastian and I will do our best to answer as many as we can during the question and answer session at the end of the presentation. You can ask questions at any time by typing them into the box on the left-hand side of your screen. If you experience technical difficulties at any point during the presentation, please outline the problem in the same question box and someone from the technical team will respond to try and resolve the issue. Don't forget, there will be the option of gaining 1 CPD point at the end of the session. So if you wish to do this, stay online and complete the online quiz question. I do not want to take any more of your time away from this wonderful presentation, so I will now introduce the speaker for today's webinar, my esteemed colleague and friend, Dr. Sebastian Crespi. Dr. Crespi is a specialist consultant in laboratory medicine. He is currently the chair of Legionnaires International, a company that provides public health consultancy services for tourism worldwide. Dr. Crespi is a co-author of the European Technical Guidelines for the Prevention, Control and Investigation of Infections caused by Legionnaire species, and the related documents on managing buildings safely during the time of COVID. The link is available on the RSPH website. He is also the leading author of the sections on water management and Legionnaire's disease of the APTA Health and Safety Technical Guide. He has also served on different occasions as consultant for the World Health Organization, the European Centre for Disease Prevention and Control, and the European Commission, mainly on the field of infections related with travel and tourism. He has a vast experience of working for the travel and accommodation industry and is a regular consultant for many tour operators, hotel chains, government, health and tourist bodies. He has helped in the investigation of numerous public health incidents in hotels and cruise ships all over the world. Over to you, Sebastian.
Thank you, Susanne, for your kind introduction. It's a pleasure to talk in this webinar organized by the Royal Society of Public Health. Thank you also Pall Medical for their support to this water webinar series. And thank you all the attendants. I hope you are all doing well in these hard and convoluted times and wish that this webinar could be of interest for all of you. Waterborne infections have traditionally been considered uncommon with a relatively low impact in the community in terms of both morbidity and mortality. But this view has gradually changed. To better illustrate its impact, this graph, published in 2017 with data from the European Centre for Disease Control, is very appropriate. Indeed, if one takes into account the lost years of healthy life due to the various notifiable infectious disease, this index is called DALIS by the epidemiologist. It turns out that Legionella infections rank fourth, only behind AIDS, tuberculosis, and pneumococcal disease. And this clearly framed in the select group of infectious disease with the highest health burden, both in the population and individual terms. Other infections that may be waterborne, and quite usually they are, like giardiasis and cryptosporidiasis, or even, although to a less extent, Campylobacter, Salmonella, or Shigella play also a significant role. How many of these infections are travel-associated? We have pretty good data for Legionnaire disease and can say safely that about 20% of them are travel-associated. As for the rest, according to different reports, this percentage can range from 10% to 50%. Yet, we have no precise data on other frequent waterborne infections like Pseudomonas aeruginosa, enterotoxigenic E. coli, or enterovirus, although we know for sure that they are quite common among travelers. The events of 2017 in Palma Nova, Mallorca, Spain, are a good example of what happens when Legionella outbreaks occur in tourist areas. In this popular touristic destination in Mallorca, there were 27 cases of Legionnaire disease during about a month, the time that the outbreak lasted. 2 tourists died. No less than 10 different hotels had affected customers. The health authorities closed one hotel and the tour operator evacuated another one, although none of them had anything to do with the outbreak. The outbreak had a wide repercussion both nationally and internationally, especially in UK, where most of those affected were. Even the British government made an informative note on the subject. Most tour operators closed sales for the entire destination. The tourist season was ended abruptly with an additional enormous economic impact for the destination. In the United States, the majority of waterborne outbreaks in the period 2011-2014, 64%, were caused by recreational waters. About 25% were from drinking water systems and 11% from other undetermined water systems, that is, systems not intended for drinking water. As for the drinking water cases, the biggest proportion seems to come from contaminated domestic water systems, including small private water supplies, like wells. About 10% are due to cross connections with non-potable water lines. This data can serve us for the purposes of this talk to setting the scene for the accommodation sites. The use of wells in certain touristic destinations is quite frequent. By the way, in Tunisia, according to official figures, 36% of hotels have wells. It is known that the well water, if untreated, can be contaminated by different microorganisms. In effect, different studies in Europe have shown that about 20% of small private water supplies, mostly wells, are contaminated with E. coli. One study in the USA revealed that 11% of the analyzed underground sites were positives for Cryptosporidium or Giardia, and one Italian study found that more than 20% of well waters used for irrigation were colonized with Legionella. Different studies have suggested that contaminated small drinking water supplies pose a substantial risk of gastrointestinal infections to young children under 10, as shown in this well-conducted cohort study where the risk of infection was particularly high when E. coli or enterococci were present. Then, at least for family hotels with children, the use of untreated well water should be avoided. The incidence caused by cross-contaminations of the potable water system are responsible for a significant proportion of cases of waterborne infections in hotels. This norovirus outbreak occurred in 2000 in a tourist resort of the south of Italy is a good example. It affected about 350 people, including 70 staff, along about 3 weeks. You can see here in the epidemic curve the typical cyclical pattern of the norovirus outbreaks in hotel settings, paralleling the turnover of tourists. Interestingly, as used to happen as well, a large proportion of staff was affected, only during the first week. The origin of the outbreak was traced to the contaminated drinking water system. The environmental inspection identified a bypass to the potable water tank from a non-potable irrigation source. A break in the feeding potable water line was also observed. The outbreak was controlled after different measures were implemented, in particular when the bypass was removed and the tank was fed by water tankers. It is generally admitted that recreational waters constitutes the source of the majority of waterborne outbreaks in hotel settings. In this study in the USA involving a large period from 2000 to 2014, more than 500 outbreaks were identified, with near 30,000 infected cases. Among the outbreaks with a confirmed infectious etiology, 58% were caused by Cryptosporidium, 16% by Legionella, and 13% by Pseudomonas aeruginosa, be the last in form of folliculitis, the so-called hot tub rash, or otitis externa, also called swimmer's ear. What is more interesting from this data is that 1/3 of the outbreaks occurred in hotels. Since Pseudomonas and Legionella could be, at least in theory, controlled by adequate halogenation and Cryptosporidium by UV and good filtration coagulation systems, it is a bit surprising to see no evident progress in preventing transmission along the years, what I have called the elusive control. Then what is happening? Otitis externa is mainly caused by Pseudomonas aeruginosa and Staphylococcus species. I have taken a look at the data of our own laboratory regarding the samples of pools from hotels, some few thousands per year, that have shown microbiological incidence in the last few years. And to my surprise, I found this trend. The percentage of positive samples to Pseudomonas aeruginosa has been on increase, passing from 1% to 5%, being by far and away the higher fraction of the microbiological analytical incidences in pool waters. I admit that this can be the result of some random variations, but I suspect that warmer temperatures and the increasing introduction of water aeration by means of air and water jets that contributes to deplete halogens could be the main reasons. Be it as it may, pool operators should try to improve or readjust the water treatment plants to decrease these figures. If there is a case that exemplifies perfectly the quest for an elusive control in the field of waterborne infections in the accommodation sector, This is travel-associated Legionnaire disease. In spite of all the efforts done by both the health authorities and the tourist industry, we have to admit that the results are far from good. My understanding is that the numbers from 2019, not shown here, have been similar to 2018. Considering a mortality rate of 6–7%, this implies a minimum of 10 deaths per year, and this can be just the tip of the iceberg. I believe that we, the people working in the public health sector and the ones devoted in one way or another to health and safety matters in the tourist sector, have the professional duty and the moral duty as well to ask ourselves what is going on. If we are doing our best in terms of prevention, if there is something more that can be done to help in this matter. I will use this particular infection as a paradigm of the quest for a better control. Different factors are likely contributing to this increase. Among them, improvements in surveillance, warmer and wet weather, or older infrastructures could play a role. In addition, aging population, that is, the increasing size of susceptible populations, persons aged 50 years and over, including older travelers, could be an important contributing factor. I have explored this possibility taking a look at the age-related rates in the ECDC Atlas and have plotted the different figures by year in these animated slides to have a visual evolution. It is clear that the huge increase of the rates has been in the older age groups, much higher in the 65+ group. Moreover, using the data of the Italian dataset, the country in Europe declaring most cases, it can be seen a clear trend towards a higher average age of the cases along the years. In parallel, more people aged 65 and over are traveling. Taking together all this, it is difficult to avoid the conclusion that older travelers could play a role when trying to explain the increase of travel-associated Legionnaire disease. Although it is true that the magnitude of the increase in the last 4 or 5 years period would suggest an effect well beyond demographic change. Be it as it may, we should ask ourselves why the preventative methods that we have in place in hotels have not been good enough to prevent such cases. I will try to dig in this matter. This is the epicurve of Legionnaire cases associated with the hotel Fantastic. This is a real case, and only the name of the hotel is invented. Since the year of its initial opening in 1990, the hotel has been associated with a continuous dripping of cases, 24 in total. In seeing this, it is clear that we are facing a case of persistent transmission, a prolonged outbreak. And here emerges another problem. Since many of these cases applying present European surveillance procedures were considered sporadic cases and not fully investigated as part of an outbreak, we have suggested that using the concept of recurrent hotels for surveillance could help to prevent a significant number of cases. We have investigated in depth a group of 54 recurrent sites from different countries and have found very interesting findings regarding the environmental microbiological isolates. About 91% of the isolates for such sites were Legionella pneumophila serogroup 1. Of these, more than half were monoclonal antibody 3.1 positive, analyzed with the Dresden European panel. This marker is considered a marker of virulence. If we consider only the subgroup for which we have map typing data, then the percentage of MAP 3.1 positive would be higher than 80%. This is a striking finding, since when we compare these results from the ones coming from routine samplings found in the bibliography, they are quite different. In effect, in routine samples, only 20–45% of the sites are colonized by serogroup 1, and of these, a mere 15% are MAP 3.1 positives. We conclude that this is a distinctive microbiological pattern of the recurrent sites. Perhaps time has arrived to consider in the guidelines for prevention of legionellosis, in addition to the concentrations, which particular strain, at least species and serogroup, is colonizing the site, if we want to assess better the risk. I believe this is particularly true when facing recurrent sites. Most of the guidelines and regulations indicate that the range 50–60 degrees centigrade is adequate for the safe operation of the hot water systems in hotels. But the adequacy of this range has been discussed in the last years, especially on the grounds of absence of correlation of this range with negative results. This is well exemplified in this graphic, where several thousands of positive results have been plotted in relation to the water temperature. In effect, these data do not suggest a clear divide at 50 degrees centigrade for negative results. More recently, a meta-analysis conducted specifically with data collected from 13 studies carried out in hotels has identified 55 degrees centigrade as the most adequate cutoff point. In summary, the study found that at this temperature and above, there is a strong negative association between temperature and Legionella colonization. The odds ratio for detecting Legionella at 55 degrees centigrade or above was 17%. At 50 degrees centigrade, the probability of finding Legionella is about 75%. If we accept that negative results imply a protective effect, then it seems reasonable to recommend temperatures of 55 degrees or higher, at least in risky settings like recurrent hotels. Another preventative strategy that can be wrong is the use of regular thermal disinfection as part of the long-term preventative programs that are recommended in different guidelines and regulations. The procedure of thermal disinfection is essentially like this. The water is heated at 60–80 degrees centigrade and recirculated during a certain time in the system. When conducted for remedial purposes, the water is flushed through the terminal points during some time. However, in the thermal disinfection carried out for preventative purposes, this later step is usually missing, thus compromising the effectiveness of the procedure, at least in the peripheral outlets. What say regulations and guidelines on thermal disinfection? This table tries to summarize the situation. In short, many of the regulations distinguish between remedial thermal disinfection and preventative, being the first usually stronger than the last. Second, some countries, highlighted in green in the table, recommend or require thermal disinfection for preventative purposes, while some others do not, as in the case of UK, Germany, and the European technical guidelines. As for the frequency, this is again very variable, ranging from daily to annually or semi-annually. Finally, in relation to time and temperatures for both heating and flushing, there is again a lot of variation. In short, in seeing this, it is clear that there is no rocket science behind this practice, and the situation varies dramatically from country to country, going from not recommended to required at weekly basis. The efficacy of the intermittent thermal disinfection has never been demonstrated. Indeed, different studies have suggested the contrary, that it could do more harm than benefit. In a preliminary, non-published study, we followed a group of hotels along a year, some of them conducting regular thermal shocks and some others not. Here you have the final results. The differences between the two groups in terms of percentage of positive samples for Legionella were scarcely significant and did not justify the negative impacts of the procedure in terms of energy cost and CO2 emissions. The industry has played a vital role in the expansion of this methodology, since it has inundated the market with different heating systems that have incorporated automatic thermal disinfection programs. These systems are marketed in different ways, but all of them have in common, in one way or another, the use of Legionella risk as a commercial target. Here as a Legionella disinfection system, or there as anti-Legionella system. But my favorite one is this that claims to guarantee the complete eradication of Legionella of the hot water systems, and even of other bacteria indefinitely. For the ones who are devoting our professional lives to the prevention and control of waterborne infections and know of the difficulties, if not of the real impossibility of a complete eradication, I believe we have the right to doubt about this claim. Has the industry went too far with this? To be honest, I must confess you that when preparing this slide, I was tempted to use this other emoji instead. Let's go back to the outbreak of Palmanova in Mallorca in 2017. Finally, after a few months with the season over, the origin of the outbreak could be traced, not without a good dose of luck, to some outdoor jacuzzis in one of the tourist establishments in the area. And this led us to talk about new sources of infection that may explain, at least in part, this increased incidence of the disease in the tourist sector. This is an aerial photograph of a hotel on the Mallorcan coast. I have to clarify just in case that it has nothing to do with the Pall Medical outbreak. At first glance, you might not see anything that catches your eye, but a closer look reveals this. There are no less than 30 jacuzzis on the outdoor terraces of the hotel rooms. These are private jacuzzis, exclusive to guests of these rooms. But the aerosols they generate are not very private, and as the Pall Medical outbreak shows, they can be easily dispersed throughout the community. Today, there are dozens of hotels that have these devices on the terraces all over the different touristic destinations. The maintenance of these spa pools in the terraces of the rooms can be far from easy, and in the practice it can be difficult to maintain them adequately. Normally, they are dosed manually, once per day or less. The recirculation is stopped at night to avoid noise. The testing for chlorine and pH is irregular, not to say about the change of water or the maintenance of the filters that used to be carried out after every checkout. In summary, whilst many private spa pools could be well operated and maintained, many others, for different reasons, likely are not. The increasing practice of the intermittent use of dual systems for heating the water, solar energy systems and conventional systems, is something relatively new that have been the most likely origin of different clusters in the last years. In effect, some hotels use at the beginning of the season conventional systems, boilers, for heating the water, switching later on to the solar systems when the weather allows that, and switching again to boilers when the solar energy is not enough. In theory, this switching is very easy, and in some installations is as easy as opening the valves, as in these bungalows. This particular hotel has different bungalows that are served by both conventional hot water lines and solar energy lines coming from the roof. Note that when the bungalows are operating with the solar energy system, the conventional hot water circuit supply and return leave dead legs in every building. Multiply this for 15-20 bungalows and you will have a huge volume of stagnant water at critical temperatures for Legionella growing. Moreover, see what happens when we switch from one system to the other. I believe that the pictures on the right speak by themselves. I cannot end this talk without making a mention to water safety in accommodation sites in the context of COVID-19 pandemics. One of the most important risk factors for mortality in COVID-19 is having a co-infection. Respiratory co-infections in particular could be catastrophic. The fact that many hotels have been closed or only partially used under the lockdowns implies that water systems have been under stagnation, perhaps for some months, being now under an increased risk for Legionella and other waterborne infections. Different incidents have been published in relation to this. Moreover, the effects of extended stagnancy have been considered and discussed by different academics and published elsewhere. Finally, I want to recommend the guidance published by the European Legionnaire Group, ESGLI, on the maintenance of water systems during COVID-19 pandemics. I believe that this can help the hotel managers and chief engineers to keep the water systems safer. To summarize, waterborne infections in accommodation sites are common and have a significant impact in terms of public health. The use of well water without proper treatment should be avoided in hotels. As for the swimming pools, better protocols and methodologies are needed for the prevention of cryptosporidiasis and ear infections. Causes for the increase of travel-associated Legionnaire disease seems to be multiple, both intrinsic and extrinsic. As for the former, aging population likely plays a significant role. Regarding the last, increasing exposure to new potential sources and subsequent inadequacies in prevention could explain part of the increase. The problem of recurrent hotels had to be specifically addressed by the health authorities, and changes in the current definitions of sporadic and cluster cases should be considered. For these particular sites, more stringent preventative measures may be needed, including a higher range for hot water temperatures and a specific Legionella pneumophilus serogroup 1 detection in water testing. Finally, regular thermal shocks are no longer recommended. Guidelines and regulations, if pertinent, should be updated accordingly. Similarly, specific updates are needed to face the surge of new epidemiological situations in tourist areas. And this is what I wanted to tell you. Thanks for your attention, and I give the floor now to Dr. Susanne again. Thank you.